Hello, I'm William Slattery of the House Clinic. In this video, we try to provide an overview of how the operating room can be set up to maximize the efficiency for ear surgery.
Most important thing is in setting up the OR is obviously to make sure that you've got the instruments that you need, the equipment that you need. Typically on a surgery day, you want to come in and check the room, check the microscope, balance the microscope, make sure that the settings are correct.
Our concerns really if we have the right instruments for the doctors and right supplies, sutures, all those things.
You need to know a basic setup. You know, if you're going after, say, a tympanoplasty, normally you don't have to worry about bipolars and neuro instruments and that kind of thing. Whereas the opposite, if you're setting up a neuro case, you need to know about KUSAs and bipolars and lasers and that type of thing. So having a basic understanding of what kind of case it is that you're doing is going to be helpful to you.
We open the supplies and equipment sterilely, making sure that nothing gets contaminated, so that way everything runs smooth during the surgery. We are responsible to set up the room, meaning our back table where we put our instruments and other supplies during the case.
We position the patient in such a way that we have an easy access to whatever we're doing in terms of where we put the instrument trays and, you know, our instrument tables, our Mayo stand.
You usually start out with the patient being put to sleep facing the anesthesiologist, and then the patient is rotated around to the opposite end, the microscope end, and that's where the surgery is done. So that would be the difference, I would say, as far as for our surgery versus general surgery.
You need to make sure, one, that you're in the right side, and that's the first thing that you do. That's why we mark the ear, that's why we check, double check.
We know exactly what instruments to pull out for each case, like what tray it is that we're going to use. And if we do, let's say, a stapedectomy, we also should have the right prosthesis before we begin the case, make sure we have all the sizes, and make sure we have the laser, you know, tested and ready for use.
You open up the whole room as far as all the sterile supplies and such, and add any extra equipment that you know that particular doctor might need for that case. What we're looking at here is a Mayo stand setup for a tympanoplasty, which will include some Wheatlanders, Limpert elevators to not only obtain the graft, but to lift the ear and do some drilling behind. So you'll need some irrigators for the drill, also some forceps and scissors to obtain the graft, and your rack of picks, which are used for tympanoplasties. Those include one knives, twos, weapons, gimmicks, Rosens, curettes, and usually a crab tree and a hook. This setup for the Mayo stand is for a stapedectomy, which always includes two racks of picks. The first rack of picks is used to do the canal work, lifting up the drum, getting things prepared for taking out the stapes. Taking out the stapes is going to involve using the second rack of picks, which are specifically used for stapedectomies. That will include Rosen needles, Barbara needles, very small hooks, and of course you would need your speculums and your forceps.
There's a flow of things when we're doing the case. We're not stalling the doctor, and we're telling the doctor, we communicate with the doctor. That's what we always tell them to do, because the doctors are always right behind the microscope, and they don't know whether the scrub tech is ready to hand him the equipment or the supply or the prosthesis or the instrument. So we always communicate with the doctor saying that, okay, it's almost ready, or we're doing this, we're doing that.
I think it's also important that you take notes, take down notes for a certain procedure, because sometimes you kind of forget, so you can double check on the notes.
Because of our instruments being microscopic, you just need to take more care in handling the equipment. Make sure you pay attention, listen to the doctor. If you don't hear them, or don't understand, it's okay to go ahead and ask them to please repeat.
Pay attention to the surgeon. He's the main guy in the surgery itself. Don't get caught up in any kind of conversations that somebody else might have. There's a lot of equipment that he may be using that he's going to tell you off on, give me this, give me that, and paying attention is going to be the most important thing that you can do.
Well, it's important to have all the equipment you need for that case, especially as from the nurse's point of view, that you brought everything into the case you need so that you don't have to leave during the case. It's inevitable that you're going to have to leave for some items, but you try to have it all ahead of time and as organized as much as possible. So you use the preference cards for that particular surgeon that will tell you what you need for the case.
From the RN standpoint, she needs to know the meds, the dosages, any kind of maladies that the patient may have. They need to be able to alert that to anesthesia or the surgeon.
So you need to know which kind of drill the surgeon is going to use, because we have 3 or 4 different kinds of drills. For a craniotomy case, you need to know that you have what kind of equipment the doctor is going to want. Is he going to want a selector? Is he going to want a different kind of aspirator? Make sure you have all the packs up here from Central Supply when you come in the morning, that we've got enough supplies for the cases. You might have to call Central and get more cases to start.
The role of the RN is they're the patient's advocate, during surgery. And so they need to be able to speak for the patient when they are unable to speak. So safety is the main concern with any patient going into surgery.
You have to make sure the microscopes are working. You should make sure that everything in the room is working, that the anesthesia cart is set up properly, because you don't want to be running for anesthesia supplies. You have to have your suction hooked up so that that's safe for the patient. You have to work together as a cohesive team. You're working with the anesthesiologist, the scrub tech, the surgeons, the assistant surgeon, the scrubs from across the street, the scrubs from over here, and we all have to be on the same page and know what we're doing. For people that are new setting up an OR, you need to take notes, because you're not going to remember this until you've done it dozens of times.
You have to love what you're doing if you're working in surgery. You have to love the chaotic pace, as it sometimes can be, not always, but sometimes, and have the flexibility to adapt to any kind of circumstances that present.
You've got the basic prep. You do the shave, usually 2 or 3 fingers around the ear to make sure that you got enough room, because hair in the wound is just not a good thing. That's introducing infection. Then you towel it off, usually 4 or 5 towels going around the site, and then your body drape, which is usually like a split sheet or an ear drape where it goes around the ear. And of course your suction, your irrigation, your bovie, your drill, making sure that you drape your microscope and slide that in, and you're ready to go.
So what we do for the microscope is there are a few knobs that you turn. There are probably 4 knobs that you turn to balance the microscope. Depending on the physician, some of them like the microscope to be more flexible than others. There are 3 eyepieces, 2 eyepieces that are centered for the doctor. We make sure that the lenses are clean. They also have different focus, negative and positive. So depending on the doctor, we usually do 0-0. Once that's done, then we go ahead and drape the microscope. We don't drape it too fast to make sure that we don't contaminate ourselves, since it's a pretty long microscope and there's wires and cords everywhere. So we try to do it as slow and sterilely as possible.
Well, we're doing facial nerve monitoring to help reduce the risk of damage to the facial nerve. So we are going to be monitoring 2 to 4 branches of the facial nerve. So it's important to know which branches that the doctor wants monitored. With chronic ear cases, we typically do 2 branches of the facial nerve. orbicularis oculi and orbicularis oris. For craniotomies, we typically do 4 branches of the facial nerve. So you're going to get permission from the patient to do this procedure and warn them that they might get some marks on their face just from using the needles. And once the patient's asleep, we prep the face with alcohol and place the needles. A lot of people use blue for the eye and red for the lip, but here since we're doing 2 to 4 branches, sometimes more, we always do from top to the bottom of the head, like a rainbow, Roy G. Biv, just so we always know which electrode is in which branch. You always want to set up the monitor on the side of the surgeon. As far as the scrub tech, if it's a craniotomy, we'll probably be opening up a Prass probe, and that has to stay sterile. So we're going to open that up for them, and once the patient's draped, we'll set up the probe for them. And you always want to confirm with anesthesiologists that only short-acting paralytics or no paralytics were used. That is important because the facial nerve cannot be paralyzed in order to monitor it properly. So we always do a tap test and a 4/4 twitch and document the time. So when we place the needles, you want to try to get as much of the area as the muscle as possible. So over the eye, you want to do it in this direction. And sort of in the video of me placing it, you can see that it's over a larger portion of the muscle rather than right next to each other. And then we drape it along the side of the face to keep it out of the surgical side. Particularly with craniotomies, you want to keep the neck clear in case you have to do a facial nerve graft for any reason. And then we drape everything out of the way of the surgeon and tape it to the top of the chest. Just keeping the leads out of the way reduces any kind of problems that might come up in the future if it gets tangled in the drapes or with other monitoring equipment. After we place the needles, we put the leads into the head box and we match the protocol on the monitoring machine. So the case that I set up had orbicularis oculi as channel number 1 and oris as channel number 2, and then the grounds. And then we go to the machine and check the impedances to make sure that they're low and that the integrity of the electrodes are good, and that we've got good contact on all of them.
Do your best to practice these techniques that we've demonstrated, and you'll be on your way to successful ear operations. Good luck. In the accompanying video, we have an overview of the ear instruments. We hope you'll review that video as well.